Good morning, students. Today we will cover biomechanics of hip complex. Now, hip joint, as you all guys know, is we see it as similar to the shoulder joint, because a shoulder joint is a ball and socket variety of a synovial joint, and we know that hip is also a ball and socket variety of a shoulder joint. But there is some differences which I will try to emphasize, though its function is almost the same, but the structures around it is also the same, but the function is little bit affected, because shoulder joint is a mobility joint, whereas hip joint is a weight bearing joint. So there's a little bit difference, the structures being the same, but their function is little bit different. So I will be comparing the hip complex as well as the shoulder complex in between, but it is very easy to you will be able to understand it easily. Why so? Because you have already studied the shoulder joint. Now if we can see, a hip joint is a ball and socket variety of a synovial joint, and it has got 3 degrees of freedom, as you all guys knows, that is flexion, extension, abduction, adduction, and internal external rotation. But the main function over here is transmission of weight of head, arm, and trunk. Fine. Now if we see the articular surface, I have got this bone with me. This is if you can see, the right pelvis bone. Now you understand the pelvis bone. The pelvis bone is made up of the ilium. It is made up of, yes, you can see it from here. Yes, this is this part, the pubic bone, and this is the ischium bone. This is the ischium. This is the ischial tuberosity. You can see ischial tuberosity is there. Ischial spine is here. Fine. You can see this is there. Fine. This is the obturator membrane. Fine. So as this is anterior superior iliac spine, this is anterior inferior iliac spine. What else you want to see over here? Interior, superior, interior, inferior. This is the acetabular notch, and where you can see a concavity over here, and this is the this is concavity. There is a fossa, and this concavity you see is almost oriented inferiorly as well as anteriorly, and this here it has been supported by a transverse acetabular ligament. Transverse acetabular ligament. So if I can repeat, this is the ilium, this is the pubic bone, this is the ischium. Fine. You can see the ischium going like this, here till here, ischial spine, ischial tuberosity. Fine. And this is the pubic, here in the pubic symphysis is there. So this is the obturator membrane. Fine. So if you can see, this is the acetabular notch, and this, if you can see, it is a horseshoe shaped structure. Properly a horseshoe shaped structure, and inferiorly this is not there. So there is a transverse acetabular ligament which is supporting here. Fine. The structure has been supported by an acetabular labrum, and this and a transverse ligament in just at inferior side. Fine. And if the articular surface you see of this that is again the right femur. This is head, this is the neck, and if you see, this one is the greater trochanter. This one is the greater trochanter, and this one which you see from the inferior side is the lesser trochanter. Now this is basically intertrochanteric line. Can you see how I am crossing? This is the intertrochanteric line. Fine. So this is head, this is neck, this is the greater trochanter, and this is the it is connected with the lesser trochanter through an intertrochanteric line. On the posterior side, if you can see, head, neck. Here you can see the lesser trochanter very nicely. This is the greater trochanter very nicely, and there is a crest. It is connected by a crest. Crest is that you give that there is in a simple word, a valley, that is which is connecting from one point to the other. Fine. We will be going this in detail when I'll tell you the capsule around it. So fine, this is the articular surface, and you can see the orientation of the head. The head is little bit superiorly, anteriorly, and medially oriented. Fine. Superiorly, anteriorly, and medially oriented. Fine. This is a very important point. So this is the structure which I have shown it to you also, guys. Now acetabulum is a cup shaped concave structure, nearly circular, horseshoe shaped structure. Acetabular fossa is there. Acetabular notch is covered by a transverse acetabular ligament in the lower part of the acetabulum, and it's inferiorly tilted by 50 degree and interiorly tilted by 20 degree. Now the head, distal articular surface, the head of the femur is spherical, 2/3 of that of a sphere. It has got a fovea capitis. Yes, I missed this point. There is a fovea. There is a little bit a pit over here in the center of the head, which is called as fovea capitis, through which ligamentum teres arises. It gives origin to the ligamental teres, and this teres basically ligament gets attached to the acetabular fossa in the center. So that means it holds the head into the acetabulum. So this head is superior, medial, and anteriorly oriented. You can see over here the acetabular labrum. Now if I can show you, this labrum is this structure. This is the acetabular labrum. This structure is the acetabular labrum. You can see inferiorly it is not covered. It has been covered by a transverse acetabular ligament. Now the light blue color structure is the articular cartilage. The articular cartilage totally covers the femoral head, but you can see it is not covering the acetabular fossa fully. In the center it is not covering. It is only covering a part of the periphery of the acetabular fossa. Fine. The socket is free, and in the center of the socket is the ligamentum teres. Fine. Now the function of this labrum is similar to that of the function of glenoid labrum. Now this is basically increasing the concavity. Now if you compare with the glenoid labrum and the glenoid fossa was a shallow cavity. Fine, but this is a very good depth cavity, a good cavity. It has got proper depth. So there is a difference between the two, but it required a very thick glenoid labrum. Here in this, it is a fibrocartilaginous acetabular labrum is there, but it is not as thick as the glenoid one, but it is also providing increase in the concavity. It is further providing increase in the stability, and which is and also been supported by a ligament from inferior side, that is transverse acetabular ligament. Fine, and it provides that yes, both of them provides the negative intra-articular pressure, so that the head get a negative suction pressure and get stuck at the acetabulum. Fine, so it is important. Another important point over here is that it is also having nerve endings. So because of that, this is giving a joint position sense or proprioceptive sense. This is a very important point. We covered it over there also. In shoulder also, we will be covering this here also. The angles around the hip joint. So first angle is the angle of inclination. Now what is this angle of inclination is, if this is the bone, it is a line which is passing through the head and the neck, and the line which is passing to the longitudinal axis of the bone. The angle which is formed inferiorly or on the medial side is said to be the angle of inclination, which is round about 125 degree. Now this angle is different in normal limits also. That means, what is that normal limit? Some say it is between 110 to 140 degree, and it varies in an individual also. From right leg and left leg, there can be a variation can be there. In females, this angle is less as compared to males, because females have wider pelvis because of that. In children, this angle is more. When the child is born, it may be at the angle maybe 150 degree, but as the skeletal matures, this angle is reduced to 125 degree. Now, but what is this condition? This is a normal condition, normal angle of inclination. Now, if this angle increases more than 125, then it is a condition called as, okay, let me see. Yes, this is the condition which is called as coxa valga. This is a condition which is called as coxa valga. I have shown you in picture. This is coxa valga condition. Now what is in this, the angle has increased. Now you can see this, the angle which is formed at the medial side, it is increased. Now what will happen because of that? If this angle is more, you can see these are the few lines which have been shown. These lines, they are not normal lines. These are basically lines of trabeculae. We will be studying that also. The trabecular system is basically the weight-bearing lines of the hip, because since it's a weight-bearing joint, so what happens is the cancellous, there is a calcification of the cancellous bone takes place, and in the form of lines which we called as trabeculae. And there is a trabecular lines are there in the pelvis as well as in the hip bone, because it's a weight bearing joint. So you can see that this since the weight bearing or the joint compression forces over here has decreased. Why so? Because the angle has changed. What angle has changed? The angle has increased, and the articulation, if this angle has increased, this shows that the line which is passing through the head and the neck, the angle has increased. So the orientation of the head has changed. the head is not no more a superior, medial and interior structure, because you can see the angle has changed. Now if this angle has changed, the articulation between the joint has changed. The joint has become an incongruent joint. That is, it is an unstable joint. Now if it is an unstable joint, what will happen is the weight bearing line will also become weak. The weight bearing line is weak, and so the trabecular system over here is also weak. Fine, this trabeculae, which is these lines have also become weak. So there is an instability of the joint which is taking place because of the increase in the angle. Then there is a trabecular system has also become weak over here. The third thing which is important over here is that we have normal, the movement arm of abductor muscles. The movement arm of abductor muscles as decreased. The movement arm is decreased. We comparing this with this. Can you see this? The abductor group of muscles, they are basically the movement arm has decreased. That is, you see that if they are not able to I cannot show you over here, but let me if I can, let me see if I can tell you from here, like this. Now if you can see, this is the bone and this is the structure we are having. So when this angle is increasing, so the abductor group of muscles, fine, the hip, their efficiency has, or the perpendicular distance or the movement arm has decreased. If I can show you over here, the line that is from the hip joint, if this is the muscle, fine, this abductor muscle is there. So what is happening is that the perpendicular distance has reduced. The perpendicular distance has already reduced. So it has become mechanically, if I can say, it has become inefficient. Now if it is inefficient, what will happen? If it is inefficient, then the gravitational adduction force which was happening around the hip joint, which will not be compensated by the abductor group of muscles, and which will result in instability at the joint itself. So that shows that the movement of abductor muscles reduces, and thereby it cannot counterbalance the gravitational adduction forces, and again the joint stability is compromised. Okay? So you compare from this is a normal line, and you compare it from here, if you can see, this is the perpendicular. If I can say, if this was the muscle which I have shown, fine, if this is the muscle which I have shown, the perpendicular distance over here was good. Here you can see it is not at all there. It has totally reduced. Fine. So the thing is that you can understand in this condition, there will be a kind of, in this condition, there will be a kind of what? The joint stability will be reduced, the trabecular system will be weak, there will be gravitational adduction torque will not be compensated by the abductor muscles because its movement arm has reduced. And another thing which is important over here is that it is causing a more compressional forces. It is causing more compression, or the joint compressional forces will increase. If the joint compressional forces is increasing, what will happen is that there will be chances of getting impingement of AVN of avascular necrosis of hip will be very much high in these conditions. Now if we take the other condition that is called as coxa vara, this is the condition, fine. Now in this the angle is reduced, the angle that is normal, the angle is less than 120 degree. In that condition, if you can see, the stability will be more herein. The stability is more. You can see the line actions, the trabecular system lines are perfect and they are good. That is, they are strong, that stability is good, the trabecular system is good, and you can see the muscle efficiency is also there. You can see this is again, this muscle is there and the perpendicular distance is also good. It is more than that of the normal one. So the abductors are also working very good along with the gravitational counterbalancing the gravitational adductor torque. So that means the efficiency or the joint stability is good. But herein, if you can see, there is another thing which is happening. This perpendicular green color line is telling us about the joint compressional forces. This is producing more joint compressional forces as compared to coxa valga. Fine, this is producing more joint direct compressional forces. So what will it result in? Because since it is the head, it is passing directly through the head. Now this angle here is reduced. This condition here, the head and the neck was like this in coxa valga, and in this condition it is like this. So the joint compressional forces is directly acting on the head here. Now there is chances of getting a condition which is called as the fracture of the head of the femur, which is called as slipped capital femoral epiphysis. This is a condition which is very common over here. Fine. So here in coxa valga, degeneration is very much common. Degeneration or avian hip condition is common, and in this condition you can see the slipping off of the head of the femur is there. Fine. Let us go through the slide. Now we understand this, that it is angle of inclination is the line which is passing through the head and the neck with the longitudinal axis of the shaft of the femur with normal angle of 125 varying between 110 to 140 degree, and the angle changes within the that is from right to left side, left hip. Angle decreases in female and it decreases with age also, 150 at time of birth to 125 at skeletal maturity, and there can be asymmetry between the both legs as I told you. Fine. In cases of coxa valga, angle is more than 125 degree, and what changes which takes place is the contact area between the articular surface decreases, thus the stability decreases, the trabecular system density decreases, the movement arm of abductor decreases as the length of the head and the greater trochanter decreases. You can see the distance between the length and the greater trochanter is less. Gravitational adduction movement is unbalanced and joint reaction force increases, thus causes degenerative changes. In coxa vara, the angle of inclination is less than 120 degree, so the following changes occur. That is increase in instability, increase in muscle strength, increase in muscle efficiency, decrease in joint reaction force. But herein it causes a bending movement. When this joint reaction force is decreasing, and there is an increase in the bending forces of the femur, which may cause a fracture of the femur, and there can be a limping which can be there due to this limb length or the fracture of the head or neck of the femur. There can be a limping movement. Then there is another which is angle which is called as angle of torsion. The angle of torsion is the line which has been formed between the head and the neck and the condylar lines. If we draw a line and ask them to follow it and then follow till the line which is passing through the condyle, the angle which will be formed is the angle of torsion. Now if we can see for this it varies between 15 degree to 20 degree. Fine. And if this is the angle, we can see the normal hip is little bit of anteversion is taking place. Now what happens is, if this angle is increased from 15 degree, that means if angle is more is there, then what will happen is again the same forces will be acting. And there is another thing which is happening is there will be in-toeing of the when the person is walking, the person will walk with in-toeing. Can you see this? This is called in-toeing of in-toe walk. That is, the gait is in-toe. The foot will be in the in-toe position. Whereas when this is retroverted, that is the angle is reduced, then what will happen is toe out-toeing will take place when the person is walking. This is a normal walk and this is in-toe walk. I have not shown the out-toe condition. Fine. So let us read this. Angle between the axis between the femoral condyle and the head and the neck is called as the angle of torsion. The normal femur is antevated, that is 10 to 20 degree. It is 15 degree in males and 18 degree in females. Asymmetry between both the limbs is seen. Anteversion of femur is increased in torsion more than 20 degree. Fine. So we say the femoral anteversion has taken place. Now there are certain changes which happens with this. If it is anteversion is there, then there is articular area, surface area reduces. There is a decrease in the movement arm of abductors. There is arthritis, and there is another thing is there will be medial femoral torsion and in-toe walking takes place. Now if these changes, they are similar to the changes which we have seen in coxa valga. Fine. The articular surface has decreased, the decrease in the movement arm of the abductor group of muscle, and resulting in increase in the joint compressional forces, which results in arthritis or degenerative changes, avian of hip. But another thing which is added over here is this brings about, the anteversion brings about a medial femoral torsion, and which results in in-toe walking. Retroversion is decrease in the torsion less than 10 degree, and falling changes occur, that is increase in the congruency. That is again we can see what happened in coxa vara, increase in their joint stability is there, but it may result in labrum tears, slipping of the head, fracture head, and impingement can take place. So this is it may result in a condition called out-toe walking. In order to prevent this kind of an impingement, the person will start walking in a out-toe position, because to prevent the pain. Now this is very important topic, angles. We have just now studied the angle of inclination and angle of torsion. Now we need to understand, we are saying that hip joint is a weight bearing joint. Now we need to understand this, what kind of forces are acting at the hip joint. Now this is the hip joint. If we can see the head, basically the head and the neck. So it is getting the now it is here, you can see a weight is been applied, that is the weight of head, arm and trunk is acting on this joint. Then there is a ground reaction force which is also acting on this. Fine. Then there is this becomes basically then there are tensile and compressional forces. There are some certain tensile forces which are acting, and there are certain compressional forces. Herein you see a compressional force is acting, joint compression which is causing joint compression, and herein you see a tensile forces, distracting forces are acting over here. But these all need to be balanced. Fine. Very nicely shown in this figure. If you can see, you can see over here is, this is the weight. The weight is acting over here, the ground reaction force is acting somewhere here. So you can see this is a perpendicular distance between the two. This is the perpendicular distance, and this two, the weight as well as the ground reaction are becoming a force couple. They are becoming a force couple. So it is causing on the medial side compressional forces, and on the lateral side tensile forces are taking place. That is, you can see this is acting as a force couple, and it is causing medially compressional forces and laterally tensile forces are acting. Fine. So this is the adaptation which we see. Now when such kind of forces are acting on the hip joint, there is certain kind of a structural adaptation also which takes place. If this adaptation, this is a normal body reaction or body adaptation. What are these? There are three structures which are adapting to it. Is our trabecular system. Our trabecular system, as I told you, it is the calcification of the cancellous bone, and there is a fine lines as the body weight bears more, there will be development of more lines of these trabeculae. There are major two trabecular system, that is the medial compressive trabecular system and lateral tensile trabecular system. We can also say it as primary medial compressive trabecular system, and then there is a secondary medial compressive trabecular system. Then there is primary lateral tensile trabecular system and secondary lateral tensile trabecular system, and then there is a trochanteric system. I will like to show you this figure. Okay, if you can see from here, the medial trabecular system, that is the primary. If I am telling you the primary one, you can see this is the primary one. You can see it's mostly vertical. It is arising from the neck and it is vertically oriented. Can you see? It is arising from the medial surface of the neck and going to the lateral surface or going to the superior part. Fine. This is the medial compressive system. Medial compressive there is, and herein you can see from the lesser trochanter also this medial secondary lines are going and getting attached here to the secondary tensile forces. Can you see? This is also this is the secondary medial. This is the secondary medial compressive system. So there is a line from the medial side which is vertically oriented, and there is a line which is almost laterally oriented. Fine. Then there is a line which is called as the lateral tensile system, which arises from the tensile system, which is basically arising from the lateral side. Fine. It is arising from the lateral side. The lateral side is it is arising from this side and moving lateral side and moving to the head. That is the lateral side, lateral surface of the femur, and moving towards the head and the neck, towards the medial side. This is the lateral primary tensile system, lateral primary tensile system. There is another fiber which is arising, which is also coming from the lateral side and getting attached to the this, can you see, to the secondary compressive system. They are almost like vertical. Fine. And then there is a trochanteric system, you can see only on the trochanter which is happening. Okay, so if you can clearly see now here, this was the this is the medial system, primary medial. This is the vertical lines, primary medial. Secondary is from the medial side going up to the and combining with the primary lateral tensile system. Can you see? It is arising from the medial surface of the femur and it is moving on the lateral side. It is moving on the lateral side and attaching with the primary lateral tensile system, which is arising from the lateral side and going to the head and the neck. Then there is a secondary tensile system, which is just a vertical line which is joining the two tensile system. Okay, and then there is a trochanteric system which is only covering the trochanteric area. Then you find there is a typical zone of weakness where you can see there is no weight bearing lines. Okay, that is of a clinical significance because fractures are caused because of this line only, because they cannot take any weight over here. So this is the adaptation, because so many forces were acting, like the weight bearing forces and the ground reaction force and the compressive force and the tensile forces. So these are the trabecular adaptation to these forces. Can you see? This is the adaptation how the weight is being carried by the head of the femur. Okay, so this is then the second adaptation which has been done is at the level of acetabulum and the head of the femur. That is, in the weight bearing position, the contact forces at the superior portion of the lunate surface of the acetabulum and the superior region of the, now if this is the surface, at the superior portion there is, and where the head contacts, if you can see over here, the superior portion, this superior portion where of this lunate surface of the acetabulum and the superior portion of the head, here is the maximum force transmission. Here is the maximum force transmission, and if this acetabulum is shallow in any form, then there will not be any good amount of weight distribution which will take place. So and this is a very important point, because in weight bearing position there is nutrient supply to the articular cartilage takes place through diffusion. So it is a very important point over here, where the weight which has been carried is at just superior portion of the acetabulum, and the head is where the weight is basically acting, or weight is where it is transmitting to the bone itself. Fine. And the next is the shaft of the femur. You can see it is an oblique structure. So the medially it is facing a compressive forces, and laterally it is facing a tensile forces. So this is how there is an adaptation to these forces which is happening. Fine. The first is the trabecular system. The second we saw is for the acetabular and the head of the femur, and the third is for the shaft of the femur. This is the adaptation or the structural adaptation to the forces which is acting on the hip. Now there is a central edge angle also. Now how do we come to know whether this acetabulum is good in depth, the depth of the acetabulum? To know the depth of the acetabulum, we have got a central edge angle. Now what a central edge angle is, we need to see is, now this is the, which I told you, the superior edge. I just told you that it is the superior edge of this acetabular notch and the head where the weight bearing takes place. Now we make an angle from the superior edge to the center. It is very difficult to show you here. I will show you here only in the picture. Now this you understand is this is the superior edge. Can you see this structure? This is the structure which was being formed. This is the acetabulum. Fine. So this point is the last point where the superior portion of the acetabular labrum. So we make a perpendicular line from the superior portion to the center of the head. This is a perpendicular line. Let me show you again. So you see this is this point is this point. If I can show, yes, this is the point where there is the superior portion of the acetabulum is there. So that means if you draw a perpendicular line to the center of the head, we see that an angle which has been formed by the normal is around about 35 degree, which is normal in normal condition. By this we come to know what is the depth of this acetabulum. That means we can calculate the depth of the acetabulum. Fine. Let us go through this. It measures the femoral head coverage by acetabulum. It also measures the acetabular depth. It should be normal is 25 to 40 degree. It is a line joining the lateral margin of the acetabulum to the center of the head, and a vertical line which is drawn from the center of the head. Now if it is more than 40 degree, that means there is a femoral acetabular impingement, that is called as pincer impingement. Fine. And if it is less than 25 degree, this is called as acetabular dysplasia, that is the acetabulum is too shallow. Fine, there will be chances of acetabular dysplasia. Fine. So it's very important point here. Now regarding the structures, now till now we have seen the articular surfaces, till now we have seen the forces acting on the hip joint. We have also seen the angles, the angle of inclination, angle of torsion, the central edge angle, and how it and its clinical importance. Now let us see the structures which are responsible for the stability, bringing about the stability of the hip joint. Now it has got a very strong capsule which brings about the stability. Now this capsule basically covers the acetabulum and the intertrochanteric line. Can you see over here the intertrochanteric line? This was the intertrochanteric line. Interiorly it covers the acetabulum and it covers till the intertrochanteric line, but posteriorly it is not covering the crest. It is 1 centimeter above. Medially it is covering only the head and the neck, but it is not covering the crest. Fine. And you can see anterior superiorly this capsule is thick, whereas inferiorly and posteriorly inferiorly it is weak. Fine. And this is the neck is intracapsular, whereas the trochanter, that is the greater and the lesser trochanter, is extracapsular. Fine. So do you understand? These capsule has got 3 kind of fibers. One is called as the longitudinal fibers, that is the fibers which run directly to the periosteum, that is the bone itself. Fine. The second is the oblique fibers, which are the innermost fibers and they are attached to the neck itself. They are innermost fibers and they are attached to the neck itself, and basically they cover the area of zona orbicularis and it prevents the distraction of the head capsule. Fine. And then there are reticular fibers which carry the which is also around the capsule of the neck and which carries the blood vessels. Fine. So there are 3 type of fibers: longitudinal fibers which are attaching to the bone, oblique fibers which attach to the zona orbicularis, that is the neck of the femur, and prevent from distraction, and the third is the reticular fibers which are basically having the blood vessels. Fine. So you can see from this structure itself that it is superiorly, now this is, you can see the joint capsule, how it is attached over here, and inferiorly it is posterior inferiorly it is weak, whereas superiorly it is good. Fine. And there is an important structure that is ligamentum teres is there. Now the joint capsule, we have seen how strong the joint capsule is, but what is the importance over here is in cases of fracture neck of femur, we always ask that whether it is intracapsular or extracapsular. If it is intracapsular, there are chances of development of AV and hip is there, but degenerative changes is there. If it is capsular, that means there will be chances of the blood supply. There will be chances of blood supply through the other arteries and blood vessels. Fine. So their chances of AVN will reduce. So this is a very common term which we say. Now the next is the ligaments which are around the hip joint, which are responsible for the stability. One of the ligaments is ligamentum teres. Now it's a triangular shaped ligament, and this ligament is basically attaching, its apex is attached to this fovea. Its apex is attached to the fovea over here, and the base is it is a triangular structure, so its base is attached to the acetabular notch. It is like this. So its base is attached to the acetabular notch, and its function is it causes high hip flexion activities. High hip flexion is more than 90 degree hip flexion, and it causes high hip flexion activities, and it damages in cases of high hip flexion activities, and because it causes medial to lateral stability of the hip joint. In high hip flexion, it causes medial to lateral stability, so the chances of getting, like in squatting position, or when we are in doing partial squats, when we are going below hip 90 degree flexion, then in this becomes activated or get taut, and the chances of injury is more, but it provides medial to lateral stability over there. We have also got capsular ligament, and which is basically as you can understand, it is inside the capsule, joint capsule. It is iliofemoral. It is iliofemoral, ischiofemoral, and if this was the bone, the iliofemoral, the ischio-femoral, it is arising from the ischion, and the pubofemoral. So you can understand from where they are arising. Fine. The iliofemoral, the ischio-femoral, and the pubofemoral. The iliofemoral is called as the ligament of Bigelow, and it is basically an inverted wide shape ligament, which is basically arising from, if I can show you again, the anterior inferior iliac spine to the intertrochanteric crest. This is the bone. Fine. So you can see to the it is arising from the interior inferior iliac spine to the intertrochanteric line. This is the intertrochanteric line. So it basically, this is the ligament. It is going like this. This is the ligament, and it is this ligament. It is line 1 here and line there. That is why it is arising from here, and it is inverted Y, because one ligament is going at the superior part of the intertrochanteric line, one is going inferiorly, to inverted Y shape ligament, and this provides stability in hip flexion in lateral rotation. It restricts lateral rotation during hip flexion. Fine. Then there is a pubofemoral ligament, if I can show you here, the pubic. So it is arising from this is the pubic bone. So iliopubic eminence, it is arising, it is arising from the iliopubic eminence, as well as the obturator membrane and the crest, and getting inserted at the neck. So this is the direct, which is getting there, inserted at the neck of the femur, and it restrained again in hip extension, lateral rotation in hip extension. And this is the ischio. This is the ischium. So it arises from the ischium and gets inserted at the greater trochanter. Now it restrains the medial rotation. So every, that is iliofemoral, restrains the lateral rotation in hip flexion. Ischio-femoral restrains the medial rotation in hip flexion, whereas pubofemoral restrains the lateral rotation in hip extension. So you can see this figure. This is in this diagram, you can see this is inverted Y shape. You can see it is intertrochanteric line, inverted Y shape, iliofemoral ligament. Whereas this you can see is from the pubic bone. This you can see green color structure, which is the pubofemoral ligament, and this is the ischio-femoral ligament from the ischium to the greater trochanter. From the ischium to the greater trochanter it is going. You can see it very nicely. Fine. Now you know the close pack position. It is very important. That is the most congruent position of the hip is flexion, abduction, and lateral rotation is the close pack position of the joint. Whereas you can see is the most weakest position of the hip joint is flexion and adduction. The chances of injury is more. That is why when we say don't sit in cross leg position while in sitting, because the chances of injury is more, because the hip is already into flexion and adduction and is the weakest joint, and easily the hip can dislocate. Fine. So this is but the comfortable position is hip flexion and abduction. Whenever we sleep, we sleep in this position. So I wanted to show, this was a very important diagram for me. That is the iliac crest, which is you can see attached with the abdominal muscles. The ASIS, which is attached with the sartorius and tensor fascia lata. The anterior inferior iliac spine, which is again rectus femoris, is attached over here. In greater trochanter, the hip rotators are attached. You can see in the lesser trochanter, iliopsoas is attached. This is the body of the pubis, where you can see the adductor muscle and gracilis muscle is attached, and ischial tuberosity, where the hamstring muscle is attached. So the function, if we will be continuing the function and the mechanics of the hip joint and the joint reaction forces around the hip in the next lecture. I hope you understand, you have understood the articular surface and the importance of the hip joint, and the accessory structures which are responsible for bringing about the stability of the hip joint. We will be continuing the biomechanics in my lecture. Thank you guys.